Waiting for the chairman. All right, welcome everyone. Thank you for being here this afternoon. We do have an opportunity to make a difference in our constituents and lives, 10.8 million Georgians, and that's what this Committee on Access to Quality Health Care is about. I'll call the meeting to order, and we will begin with Chairman Hawkins discussing surprise bill, House Bill 888. If you can just read the LC number so that all our committee members can make sure they're looking at the right copy.
LC 460302S. And I appreciate the committee's indulgence again for a hearing. I'm only going to go over the changes from the last bill that you had. And there are not many changes, but they're changes that do make a difference for the patients of Georgia. On line 28, we've added calendar year after 2017. On line 30, we added department, meaning the Commissioner's Department of Insurance. We've also added on line 31, and shall not include Medicare or Medicaid rates. Okay. On line 36, just a small change. It said state who render, and now it's state to render. Just a clerical error there. Then we go all the way over to page 136. I asked them to include deductible, and the reason for this is that health insurance policies are not all the same. There are some that you pay co-pays, and then you get to the deductible on major healthcare events. On some policies, you pay deductible first and then go to the co-pays, so that added deductible there. On line 161, there's a new section, E section, says in the event a covered person receives emergency medical services from a non-participating facility, the non-participating facility shall bill the covered person no more than the covered person's deductible, co-insurance, co-payment, and other cost-sharing amounts as determined by the person's policy. What that alludes to is we've added the out-of-network hospitals to be able to arbitrate in emergency services only. I think this will be important in some of our rural hospitals. On line 179, excuse me, we added the word deductible again, and that's in the non-emergent section, so it mirrors the emergent section. And then over to page 8, line 247, out-of-network was added after if and out-of-network provider. On line 248 was added or if an out-of-network facility concludes that payment received from insurer pursuant to the code section, and you notice the -4, that's the emergency code section, is not sufficient. Also on line 256, we heard from some of our medical specialties, and so we've added an additional category there, multiple substantially similar healthcare services in the same specialty on multiple patients. Then on line 268, we've added facility after provider. On line 277, again, we've added facility. That's in the arbitration portion. And Mr. Chairman, that is it. We have a bill that the hospitals agree to. We've got a bill that MAG agrees to, Medical Association of Georgia. Their specialty groups agree to. I've been in discussions with the representatives of the insurance industries in businesses here in the state of Georgia. They're waiting to read this fully, and I understand that, but I expect that and hopefully suspect that they will also agree. So we've actually got a bill this year that people like and agree, and if passed, will help the patients of Georgia in surprise billing.
Thank you, Mr. Chairman. Are there questions or discussion from the committee at this time about the changes, about the bill? Hearing no questions, do we have, is there one who's wanted to speak to the bill? Jeremy Betts, unless he waves. No, come on up, that's fine. Thank you, Mr. Chairman. Thank you.
Mr. Chairman and members of the committee, I want to thank you for the opportunity. I'm representing Atlanta Hand Specialists on this issue. Specifically, it's a small ASC. One point that we would bring up would be the CPI reference. As a suggestion, might look to the CPI for healthcare rather than just the standardized CPI that takes in more of consumer goods. Secondarily, my client is concerned about network adequacy within the current legislation, but for the sake of time, I will stand down.
Any questions from the committee? Thank you for participation. This time we had notified that, are there any other questions from the committee or any all right, if not, we have announced that we were going to have a vote on this tomorrow morning. We will be meeting again at 8 a.m. tomorrow morning. I appreciate the chairman for the work on the bill and for the changes after the feedback from this committee, from concerned members. That's I know that's much appreciated. All right. At this time, we're going to move on to a package of bills that has been that has received a good bit of attention and a good bit of work in an effort to protect Georgia patients and their ability, access to pharmacists and pharmacies and medications, as well as affordability. So it's something we're going to work on. These are actually the next three bills we'll hear today, and there is a fourth bill as well that's part of a package to address the challenges of pharmaceutical prices and the ability of patients and their insurance to cover it and to cover it in a way where they're able to get the care and continue the care that they need in a safe and effective way. At this time, I'm going to recognize Chairman David Knight to begin and present House Bills 946 and 947. I'll let you start in whatever way you want to discuss these. Chairman Knight.
Thank you, Mr. Chairman.
Go back to the opening, show taskbar, display settings,
Technology, great.
Here it is. We'll start from the beginning. Here it is. Here it is.
Thank you, Mr. Chairman, and members of the committee, and to all who have come today. As we've talked about, healthcare is a major issue, not only in this state, but in this nation. And on January 7th, this committee met to discuss what I would call the corporate takeover of our nation's healthcare. In short, some of our nation's largest and most profitable publicly traded companies are bleeding us of money and choices. They're taking hundreds of millions of Georgia healthcare dollars and a massive share of our healthcare decisions. And I stated then that we're going to take both of those back. This legislature has done some great work on that in the past, but the PBMs and managed care companies haven't been discouraged from their self-serving practices, like obscuring the prices of prescription drugs with complicated methodologies, forcing patients to more expensive brand name drugs and refusing coverage of cheaper generics to pad the profits of the PBMs and the CMOs via rebates, or reimbursing PBM and CMO affiliated pharmacies more than their competitor pharmacies and retail independents. This year we will finish the drill, and as the chairman spoke of, there will be 4 pieces of legislation. Today, we're going to hear HB 914, 946. Chairman Cooper will be explaining 914 later. But these 2 bills bring true transparency to prescription drug market, while at the same time closing loopholes in the existing laws that managed care organizations, PBMs, and even the state-contracted PBMs use to continue to engage in practices that harm patients. And the next bill I'll present will be HB 947, which seeks a carve-out of prescription drug benefits for Medicaid managed care. West Virginia did this in an actuarial study showed that the carve-out saved over $50 million, while at the same time paying out community pharmacies fairly. And again, at the same time, that was a savings. With that, we'll begin. Just to set the background, you've heard me say that these are some of our nation's largest and most profitable publicly traded companies. This is as of March 2019. 2020 numbers for the year ending December of 19 are not out yet. But as you can see, the ones that are highlighted are your insurance companies or your managed care organizations. And if you look at the numbers, they're astounding. But let me tell you what those numbers are. The first column, that's in billions, not millions. That's in billions of dollars. And I will note that number 51, Centene, and number 155, WellCare, which are 2 of Georgia's CMOs, they merged this year. So we will go from 4 to 3. How did they do it? They did it with vertical integration. No longer are health insurance companies or these PBMs acting independently. They vertically integrated into healthcare. And as you can see, the insurers, they all now have the PBMs. And up under that, you'll see the specialty pharmacies. They own them. And it's not only the specialty pharmacies that we see here. It's also the other mail order pharmacies, and in some cases, retail pharmacies. So they're designing plans that, again, are steering patients into their channels. Let's go over the bill. Section 1, we're looking at the definitions. And what we've done is we're looking at the definition of patient steering that strengthens the laws that were passed last year prohibiting the practice of PBM steering to the affiliated pharmacies. As you can see examples, the PBM, and then again going to their pharmacies, retail, mail order specialty, or mail order and specialty pharmacies. I want to remind you that last year, this body, the House and the Senate, overwhelmingly, along with the governor's signature, passed a bill that was among the first in the nation in a law that prevented anti-steering. And that was across the board in the different markets. We're seeking this bill to make sure that we strengthen that definition. But you want to know what steering looks like from a patient perspective? That's the letters that they're receiving. So again, these companies will do anything to skirt and get around Georgia law and the will of the legislators and the governor. As you can see in this one, they're not telling you you can't go somewhere else. They're just telling you that if you go somewhere else, it's all on you. You're going to pay 100% of the cost. Also want to point out that what we're seeing PBM to PBM cross-referral steering. The games that they play, they're hidden behind the scenes in the contracts that are proprietary and confidential. Last year we had an argument and we actually exempted Medicaid, managed Medicaid, out of the steering. This year we seek to put them in. And what we found through open records was that there was massive steering going on in managed Medicaid. Peach State, which is owned by Centene, which also owns a Carrier Health Pharmacy. In 2018, Peach State was paid $500,000 for prescriptions. Peach State ended up paying a Carrier Health $24,700,000 of it. Almost 22% was steered to a carrier, which was owned by Centene. And again, this was gathered through public information, open records. You know what it looks like in a contract? The language up there. I can't even believe this. This was taken from some of the open records of the contracts that we got. PBM acknowledges and agrees that Ingenio RX may steer. Looking for my phone. I don't know where's my phone. That may steer to any pharmacy or pharmacies of Ingenio's RX's choice through any means. And I'm sorry, I'm looking for a phone here. You got a phone? No, I need my dial number. You know what the story was behind this? A young lady in rural Georgia, a first-time mom with a newborn baby, received her benefits through Medicaid managed care via Amerigroup, which is Anthem. The baby was born at 36 weeks gestation and spent 5 months in NICU. And before being discharged to return back to home, the baby was prescribed a prescription for pulmonary hypertension. When the mother went to go fill the prescription, it was rejected by Amerigroup. There's a rejection. And it was told you had to use an Amerigroup approved pharmacy.
Thank you for calling Ingenio RX Specialty Pharmacy. If this is a medical emergency, please hang up and dial 911. Si necesita...
We wonder what's going on in rural Georgia and why we can't have health care in rural Georgia. It's profit over the health care of the patient. Section 2 of the bill increases the fines and penalties for violations, and it provides the commissioner with the authority to suspend the license for violations while a company may be on probation. Section 3 of the bill, physicians are becoming more concerned about prior authorizations and other practices because they're not clinically sound. It imposes standards for PBMs employing or contracting with physicians for formulary management and prior authorizations. Section 3 of the bill. Section 4 of the bill, excuse me. It increases the commissioner authority and includes the abilities to conduct financial examinations and compliance audits. It's similar to what we've got in other code section. And it also removes the handcuffs from the commissioner through some language that's in the code that says he may not enlarge upon, extend the specific provisions of this chapter through any act, rule, or regulation. Guys, we've got to do something if we're going to take this seriously. Next is the heart of the bill, which is transparency. The trade secretive methodologies and the lack of transparency, retroactive fees of these companies is truly impossible to know what the true cost of a drug is. This bill seeks to make sure that multi-source generic methodologies are reported to the commissioner. It also seeks to make sure that there's a report where there are claims that are 10% above or below NADAC. Again, transparency. We're going to compare what they're doing versus NADAC. It prohibits reimbursing affiliate pharmacies more than non-affiliates, and it prohibits retroactive fees imposed on pharmacies or other dispensers tying the patient outcome to the price of the drug or utilizing patients and pharmacies as an income stream. We're also going to make sure that 100% of the rebates from the manufacturers are passed back to the plan. We're going to prohibit expressly spread pricing. And worst of all, one of the worst practices I've heard this year is the copay accumulator, whereby a PBM that sets funds from a copay assistant plan or on behalf of a patient. But the PBM we're going to make sure that they must apply it to the patient's deductible. No more double dipping. And we're also going to make sure that this law applies to DCH and the state health benefit plan. Apparently there was some confusion last year that we didn't find out until open records that DCH thought that anti-steering did not apply to the state health benefit plan. You want to look at spread pricing? In 2018, thanks to Chairman England and Chairman Hill, we put language in the budget that required a report, the line 920 report. So for the last 2 years, we've looked at spread pricing. In 2018, $50 million in spread pricing. Peach State alone had $29.8 million in spread at a percentage of 25%. 19, $43.5 million in spread. AmeriGroup had $22.6 million in spread at 18%. Over the last 2 years, that's $93 million in spread pricing. $93 million. And so what they're doing is they're billing the state $93 million more than what they're paying the pharmacies for the cost of the drugs. Section 7, we're going to strengthen the Pharmacy Protection Act. We're going to make sure that steering protection on those limited distribution drugs that are not regularly carried at pharmacies or oncology practices, we're going to extend that so that all of our specialty folks, not only the cancer, the oncology doctors, but the MS and the other specialties have access to make sure that they can treat their patients and treat them the way they need to. We're going to protect patients from brand over generic mandates, which can increase cost and delay care. Protect the patients from lemon dropping. It's a practice by which they remove a drug from a formulary for the purpose of incentivizing a patient to look for a different plan. And we're going to apply all these protections to patients in Medicaid, managed care, and the state health benefit plan. Speaking of the practice of designing plans and formularies by which we've heard testimony in this committee, whereby these formularies and these plans are actually steering us to use brand drugs when there are cheaper generic drugs available. If you look at that, it's a rejection, no overrides. But I want you to listen to this. Well, technology fails you again. If I can get this up later, we'll play it. But what this was a phone call between, I guess, a plan administrator and a pharmacy benefit manager. It's a recorded phone call whereby they're asking about this issue, specifically about these drugs. And the PBM basically said, look, we know that it's going to these brand name drugs. And the lady says, we're seeing this, but you're saying that if they go to the generic, they would have to go through an appeals process. And if they did, then they would have to pay the copay on the highest tier that was in their plan. And he basically said, yes. This is intentional, people. This is intentional, and it's based on money, and it's based on profit. Section 8 of the bill imposes 10% surcharge on PBMs and their health care plans insured under Title 33 when PBMs continue to engage in steering or when they continue to engage in imposing retroactive fees. And finally, at the end of the bill, we clarify that the General Assembly's intent is not to usurp federal law. That, Mr. Chairman, is House Bill 946, and I'll be happy to quickly do 947.
Go ahead.
947 is a very simple bill. It's very short, but it's very clear on what it does. As we've talked about the vertical integration in managed care, through open records and, again, getting at the data, we're seeing instances like this where Centene, which has the Peach State Managed Care Plan, we know that they were paid $109 million just off the top for the fees. We know that they own Involved Pharmacy. They also own a Carrier Health Pharmacy. And as we talked about earlier, the $122 million that was paid, okay, to the plan, 24 million of it went to their pharmacy. And look at the spread, $29.8 million in spread that they have. This is what's going on. Nobody's looking behind the curtain. There's no transparency in these contracts or how the contracts are structured that allow these companies to make this kind of money. If you think there's not profit in markups in drugs, in the second quarter, no, this is the first quarter of 19. This is a generic cancer drug. The NADAC, which is on a per unit pill, was $3.33. The payment was $24.90. They made $2,022 per script. Managed care again. This is an HIV drug. Same thing, $26 per pill was the cost. We paid $38.94. A profit of $382 per script. Over the interim, I've been doing a little bit of work. We keep going back to rural Georgia, and not only rural Georgia, metro Georgia, as we find out. And I've asked pharmacists from all over South Georgia, the coast, mid-Georgia, North Georgia. And I've asked them to aggregate their claims data when it comes to Medicaid for the last 6 months. Store A, over 6,500 claims at a $38,000 loss. Store B, 4,900 claims at over a $28,000 loss. Store C, 1,100 claims at over a $3,700 loss. And finally D, 2,700 claims at greater than a $12,000 loss. You've got pharmacists out there who are taking care of patients, and they're actually taking money out of their pocket on these Medicaid transactions in order to take care of the patient. But yet Georgia continues to contract in a way that allows this to go on. So with that, with steering, spread pricing, the high administrative expenses, markups on specialty, high profits, squeezing out other pharmacies through low end reimbursement, this bill proposes that Georgia engage in an actuarial study to assess the fiscal impact of a carve-out. We've instructed in the bill that if there's savings of $20 million or greater, DCH is tasked with carve-out of prescription benefits by July of 21. If that savings is between $10 million and $20 million, they're empowered to proceed. I will remind you, a study in West Virginia carved out the benefits, and the actuarial study reflected approximately $50 million in savings. And I would dare say that Georgia is a little bit larger than West Virginia in its Medicaid population. Mr. Chairman, with that, those are the two bills, and I'll be happy to answer any questions.
Thank you, Chairman Knight. We'll open it up for the committee for questions for Chairman Knight about just specify which one you're asking about. 946 is the larger bill. The carve-out the carve-out study is
947.
947. So, Representative Bentley.
Yes, sir. Thank you, Mr. Chairman. Thank you, Chairman Knight, for your work on these two pieces of legislation. But I have two questions for you relating to the larger bill, 946.
Yes.
For individuals that believe these pieces of legislation is going to negatively impact rural Georgia in terms of increasing the cost of health care in Georgia, how can you address those concerns?
Well, I think the numbers speak for themselves. They're already getting hurt. I know where you're from, Butler, one of my favorite places. One of my best friends, his mom and dad grew up there, or his mom grew up there. Actually, the Theus had the old pharmacy.
Right.
And we're seeing, just like everyone is seeing in rural Georgia, healthcare getting squeezed and squeezed and squeezed. And so right now, they're in trouble. And as we talked about the numbers, and the numbers will play this out, in rural Georgia is where some of our most underserved people are.
Mm-hmm. That's true. And
it's a downward spiral. And I would tell you that this bill brings transparency to the process. We've got to look behind the curtain and open up the black box of what's going on in healthcare, and particularly prescription drugs. And oftentimes in rural Georgia, not only rural Georgia, it's all over Georgia, even in metro Georgia, our pharmacists are the first line of healthcare. And so I would tell you that this brings transparency to the table, and we're going to start seeing and uncovering the games. And when we do that, we can affect change, and we can affect the contracts, and you and I as legislators will be able to make sure that the dollars that we appropriate in the budget are going where they need to go, and that's to the patients.
Thank you for that. My last question. For those groups that feel like they didn't have an opportunity to be a part of this discussion on these pieces of legislation, how can you address those
I'm sorry,
concerns?
who?
I think there's some groups or maybe that feel that are part of the,
What groups would you be?
the benefit managers, feel that they may have, should have
Well,
been a part of at the table, be a part of the discussion on the
Well,
legislation?
for the last 5 years, we've had discussions, and
Okay.
we've addressed these practices.
Mhm.
And we've compromised and compromised till we had some victories, but largely we've compromised ourselves to the point where we weren't doing what's right for Georgia citizens, their health care, or the providers that are out there serving the patients. And I would tell you, they've been here. We just agreed to disagree. And I would also state that when we want to talk about coming to the table and talking together, when you hide behind the curtain and have all of your secrets locked up in the black box so that there's no transparency, or you refuse to give the data, and I've got to spend 6 months or even a year doing the research to get the data that we saw here, they don't want to talk. So I would tell you, they're at the table, they just want it their way and only their way.
Okay. Thank you for your work on these two pieces of legislation.
Thank you.
Chairman Houston.
The bill we passed last year, did we get any data back from that about the rebates and all that? Have we gotten any information?
You mean the anti-steering, is that what you're
Yeah,
referring to?
uh-huh.
Chairman, we're seeing some change there, but it's slow and it's in different types of plans. But as I saw in open records with DCH, I didn't find out until this fall that DCH said that the steering didn't even apply. The bill didn't even apply to the state health benefit plan. So,
Why didn't, I mean, I don't understand that.
well, they were relying on some provision that was not true. And so we're seeking to clarify that. But we are seeing some change. In fact, we're seeing other states start to look into the measure that we passed last year. And we're going to come back and strengthen that. Again, it's about patient choice, and it's starting to help.
Has any other state besides West Virginia done this, or that you?
There, I think Kentucky, maybe they've got a study that's done that. There's several others. So I'll remind you, what NADAC is a benchmark. That's what we currently use for fee-for-service. And that NADAC is a number that is done, survey that's done for CMS. So it's a public benchmark.
Thank you.
One question. I know in the second section you talked about raising the fines that could be imposed by the department. Do you know if any PBM has been fined for what's obviously been some, or are you confident you have now they have the tools they need to enforce this?
Chairman, that's a great question. I personally don't know of any, but quite frankly, I think it's why we're coming in and reworking these definitions, going in and making sure that the commissioner has the tools that he needs to provide proper oversight and, quite frankly, meaningful penalties. Again, these are some of the nation's largest publicly traded companies, and we need to make sure that the penalties we have are meaningful.
No other questions right now. Thank you, Chairman Knight.
Thank you, and committee, I appreciate your attention to this. It's a very, very important matter.
Thank you. At this point, we're going to go to Chairman Cooper for House Bill 918, because these are a package. We're going to go in and present 918 now and go from right here. Thank you.
Thank you, Mr. Chairman. You know, across our nation right now, there's a big discussion going on between socialism and capitalism. And after working on this issue and learning what I've learned about it, you know, I can really understand better why anybody would consider socialism. Corporate greed is just out of control with the PBMs. And it's hurting our patients. PBMs do not produce a drug. They do not see a patient to order that drug. They do not fill a prescription. In fact, they don't do anything, but they're a pass-through. And they have found ways to game the system. They were originally meant to get an administrative fee, but they found ways to take the rebates and to steer to their own pharmacies and back and forth and make millions of dollars. What was the first one? $3 billion in profit, while they're squeezing the very lifeblood out of our pharmacists, especially in small towns across Georgia, where maybe there's only one pharmacist to fill prescriptions for patients. I'm just appalled. I got into this last year with CVS and saying that they bought Anthem, that if you were an Anthem patient, you had to buy your drugs from CVS. Well, just like I'm for choice when you choose your doctor, which one you want to go to, I'm for choice in which pharmacy. And especially since there's such a wide range of what things cost. My pup has a brain tumor right now, and he has seizures. And the neurologist, the dog neurologist, gave me a prescription, and I went to CVS, I went to Walgreens, and because that's where I normally get my medications. And the prescription was $406 for a 30-day supply. So I went, I love Sophie, and if that's what I would have had to pay, I would have paid it. Because I could, but not everybody can. But I decided I would shop around. I get that prescription filled at Sam's for $28. Shopping around and having the right to go to the pharmacy that you want to go to can make a major difference, even if there's some insurance company paying for me, or you're on Medicare, or whatever. Patients deserve that right to try to save money. And then to learn after we had passed the bill last year that they found a way to get around it and just sort of shove it down our throats. So we said they couldn't steer the patients to people they own. So what do? You ask him, let me tell you what they do. They say, oh, you don't have to use CVS Pharmacy. Go where you want to go. But even though you have insurance with Anthem, we just won't pay for it. You'll have to pay for it totally independent if you go outside our system. So that's how they're getting around it. So that's how I got involved in this. And then later on, I'll tell you the other thing that put me over the edge. But one of the things that put me over the edge, and I didn't know about this baby with pulmonary hypertension, my sister died from pulmonary hypertension. As a pediatric nurse and an educator, pulmonary hypertension is extremely, extremely dangerous. And an infant, it can be fatal. And to have to wait 3 weeks to get a baby on that medication is criminal, because you have to go a certain place and order it. And that was happening with our cancer patients. Who in this room, if you got a cancer diagnosis, would like to go to CVS and be told you have to get it mail order, and you're going to have to wait 3 weeks, and you're going to have to buy a 3-month prescription, even though cancer doctors often start you off right there in their offices in the past, and you may not be on a medicine more than a week or two because it may not work for you, and you may have to go back to them, and they change that expensive cancer drug. But then you are sitting, like many of the people that have talked to me, with a bag full of medicine that you can't use. And then they have the audacity to go in to our pharmacist and put them through hell and audits and say, we're looking for waste. Well, patients coming in with a bag of medicines that they've gotten over and over and unfilled and not using anymore from pharmacies, that's waste. But nobody's going after the PBM. And I will tell you, one of the smartest people in this state is Jean Sumner. She is the dean of Mercer School of Medicine. She's a doctor. She started out a nurse in and her father was a doctor in one of the poorest counties in this state, if not the poorest. And she drove back and forth, first to become a nurse practitioner and then to become a doctor, so she could deliver care to the poorest people in our state. And Jean Sumner came and testified at the PBMs and said they're useless. They don't do anything. And when Jean Sumner speaks, I believe it. So that's my soapbox, because it's about patients. So House Bill 918, House Bill 918, we got the one, all right? Representative Knight has shown you examples of what's steering, and that it still continues and it's evolving. Pharmacies affiliated with PBMs and insurers continue to be complicit themselves in these patient steering schemes. And of course, last year we passed rules to try to stop it. So what this bill is doing, it's going to mirror Representative Knight's House Bill 946, but this is on the pharmacy side. So in Section 3, it updates definitions of referrals to include cross-referrals between PBMs and insurers, increasing plan or patient cost if patients don't use affiliated pharmacies, and including making patients pay full cost of drugs. To address that problem, and that's addressed in Section 3, and it applies protection to patients on limited distribution drugs not commonly carried in pharmacies also. Section 3 also removes an exemption for Medicaid managed care. It also removes an antiquated section in our law that DCH was able to use to allow CVS to continue to mandate that our state health benefit plan, one that already state employees say is costing them too much, and every year the cost goes up, and we have to pass that on to our teachers and our state employees. People making not $100,000 a year, but in that $40 or $50 or $60 or $70,000 range that are eking out a living. So it takes care of that and eliminates that one. And then we get to the update on the audits. Well, I really didn't understand audits. I'm not a pharmacist. And in their place it says it limits the claims to 100 claims per audit and not more than 200 a year. And I'm going, wait a minute. You're telling me they could only look at 100 prescriptions? What are you talking about? And then a pharmacist came and walked me through what it takes to get to this 100. And the hours they spend after working at the pharmacy to get ready for it. You know, they have an area and a time frame that they're working from for the audit. They keep their prescriptions in 100 prescription packet. You know, so I filled 100 prescriptions, they all go together, the next 100, and they're in sequence. To get ready, they have to go through every single one of those just to make sure that there's a signature that's got the date they were filled, what time they got the prescription, on and on and on. Nothing that has to do with patient care or fraud or waste. And then the PBM comes in and says, I want to see prescription 2,567. And guess which ones they pull? They pull the ones of the most expensive drugs. And if you don't dot one I across a T almost, then they disallow that. And the pharmacist eats that cost. If the drug costs $400, then the pharmacy eats that $400 cost. Now, I've run a business. My husband was a physician. You know, my employees had a retirement plan. I pay for electricity, I pay rent. You know, I know what it costs to run a business. I can't imagine functioning. It was bad enough in medicine, but functioning when with all the different CONs and the different people that come to audit you, thinking you probably get an audit every two months, and they can go back and recoup thousands and thousands of dollars for you, even though you were not trying to defraud the company, that it's over some small clerical error. Why do we even have anybody wanting to be a pharmacist now? Pretty soon we're going to run out all the doctors out of medicine, and we're going to run all the pharmacies out, and we're going to be in one big mess. So in Section 2, it updates the Audit Bill of Rights, protects pharmacists from overburdening audits, says you can only go after them if it's really for fraud and really major problems. And it increases the commissioner's authority. And tomorrow, I think it's tomorrow morning, I'll have another bill. Because now they've done something else, and this shows you just how much heart the PBMs have. If I were to come down with cancer and I had a $300 our $3,000 deductible in my plan, and I couldn't pay for it. And I needed an expensive cancer drug. And the company said, we will pay for that drug up to $3,000. Then you can use your insurance and you can pay your copay. Well, that's what they used to do. And the PBMs would let patients do that. Not anymore. The companies can pay that $3,000 deductible, but it never accumulates to where you no longer have a deductible. So if the Cancer Society wants to pay it, or if Matt wants to pay my $3,000 deductible because he's charitable, you can give it to him, but it won't ever wipe away my deductible. So in essence, the PBMs are saying, and running their nose at us, to charity, something that Americans pride themselves on. They have no value. They are hurting patients, and it is behind the time for us to do something. And, you know, I sort of said at first, I have enough to do. This is not direct patient care, but yeah, it is. And I'm glad to sign on and try to move, you know, and to work with people and help us change this in our state. Somebody has to step out, and I want us to be one of the first steps to step out, states to step out, not one of the last for a change, and say that we're here as a Republican-controlled legislature to look after the patients of Georgia and that we care. Because I know one thing, I certainly care, and that's one of the reasons I ran for office. Sorry, Mr. Chairman, I'm pretty passionate about this. Thank you.
I know that your passion is for patients, and that's no defect. That's strong. Thank you, and thank you for these three bills. At this time, are there any questions from the committee? Chairman Knight.
Thank you, Mr. Chairman, and to my friend and Chair, I too, the disdain for the copay accumulator issues that are going out there, but I do want you to know we put this in 946. It is in there.
I checked.
And so this is probably one of the most egregious practices that I've ever seen. Thank you, Madam Chair, for helping with this and your fight for Georgia patients.
We do have some, if there's no other questions from the committee, we do have some public testimony. At this time, I recognize Jesse Wethington. We are attempting to keep our own schedule, so I appreciate your consideration.
Thank you, Mr. Chairman, and with your permission, I'm signed up to speak on 946 and 947, so can I just do both of those?
Both is fine, thank you.
Thank you. Thank you, Mr. Chairman, members of the committee. My name is Jesse Wethington. I'm here to speak today on House Bill 946 and 947. Just for clarification purposes, for 946, I will be speaking on behalf of the Georgia Association of Health Plans, which is the commercial insurers trade group, and then I will let you all know when we move into the Medicaid portion of 947, I will be speaking on behalf of the Georgia Quality Healthcare Association, which is the Medicaid managed care entities. So just wanted to be clear about that.
And just real quick, just to be sure, just for everybody who's taking notes, we're on 946, we're over LC 338313S, that substitute. For 918 was LC 338316S. And on 947 that you're going to speak on, it's LC 338207. So anyone? So please go ahead. Thank you.
Thank you, sir. PBM issues have been a hot topic around the General Assembly this year and in recent years. I'm going to keep my comments pretty brief and high level as it relates to 946, which is the commercial PBM regulation issue. You've heard a lot about this recently, and what should be clear to everybody from the testimony that's been given so far, primarily from the pharmacist and oncology side and then the patient advocates that have come and presented to the committee earlier in the year, is that this is a very complex and opaque area of the healthcare sector, probably the most complex and opaque, given all the different topics that you all deal with. This has got to be one of the most vexing. It is characterized by lots of negotiations by different parties that touch the price of a drug as it moves from the manufacturer down the supply chain to the end user. There are many contractual arrangements between parties along that chain and within it, and there are several financial transactions that follow that drug as it moves from the manufacturer to the patient. There are multiple players involved. We've heard quite a bit about pharmacy benefit managers and health plans, but there are other factors and other entities that have more or identical influence to the price that a drug costs, either to the end user or how the pharmacist is reimbursed for that drug, including the manufacturers, the wholesalers and distributors, the pharmacies, and as well as the payers and the health plans. You know, there's a ton of confusing acronyms. You know, I've got a glossary here, but you've heard about NADAC as a price index. You've heard about manufacturer acquired cost was something that was discussed many years ago. One of the original versions of this proposal over in the Senate deleted the MAC law and wanted to replace it with NADAC. That's been changed. I believe that's been changed in this substitute as well. So from our perspective, that is better. But you know what we haven't heard about is entities like pharmacy services administration organizations, group purchasing organizations, and some of the different copay charities that have been put together by the manufacturers to deal with some of these issues in terms of the cost and affordability of the drug for the patient. We are focusing on these bills in one part of the chain. We would suggest as an industry that if transparency is good for PBMs and health plans, it is good for wholesalers, manufacturers, PSAOs, and distributors and pharmacies as well. So our industry would be willing to provide suggestions in terms of widening the scope of this to legislation that's been adopted in other jurisdictions. I believe many of you have had conversations with various members of our organizations about that in terms of bringing manufacturers' notification requirements for list price increases into this, as well as registration and transparency requirements for pharmacy services administration organizations or GPOs, which affect the acquisition costs that the pharmacy is able to obtain the drug for. Why do PBMs exist? You'll hear a little bit more about that from later speakers, so I won't spend a lot of time on that, but it is to address the growing cost and inflation in brand name drug prices that the end user pays, which increased by 58% from 2013 to 2017. So it is an attempt to control cost and keep drugs affordable for the end user in aggregate. PBMs provide many services to their customers, be it health plans or employers that sponsor the plans for their employees and their families or retirees. They engage in claims processing. They engage in price discount and rebate negotiations with manufacturers and drugstores. They do formulary management, which is partially covered in this bill. They maintain pharmacy networks. They do have some mail order components. Many of them are affiliated with or operate specialty pharmacies, as you've heard. They do drug utilization review after the fact, and they do disease management and adherence initiatives to make sure that patients are appropriately taking their medications and that quality can be assured. Again, I mentioned that transparency, you know, if it's good for the goose, it was good for the gander. And we've heard a lot about self-dealing in the PBM industry for the last couple of years, but what we haven't heard much about is that the nexus between drug wholesalers and pharmacy services administration organizations. Drug wholesalers own the 3 largest PSAOs in the United States. In 2017, the largest PSAO was Access Health with 5,900 participating pharmacies in their network. They're owned by McKesson. The second, LeaderNet, MS Center and Managed Care Connections, 5,600 pharmacies owned by Cardinal Health. Elevate Provider Network, 4,500 pharmacies owned by AmerisourceBergen. So again, there is a nexus between these entities that is not being explored at this point and would provide value in terms of increasing transparency if the state of Georgia is going to be looking at this. And back onto the Georgia landscape, and I think you will hear some more about this later from other speakers, and specific items in some of these bills are what you passed last year in House Bill 233 and House Bill 323. What have you already done? Georgia is a leader in tackling this issue. We are not lagging behind. There have been many pieces of legislation brought, and many of those representatives from the health plans or the PBMs have been able to negotiate with the pharmacy lobby and arrive at an agreement. Not all the time have we been able to do that, but you've already passed a Bill of Rights, which is being addressed by one of these bills. There's requirements for conducting audits there. I'm not speaking on 914, so I'll set that aside. You require PBMs to report payers the total amount of rebates collected and retained by the PBM. Georgia prohibits mandatory mail order. Georgia prohibits copay clawbacks, gag clauses. You allow pharmacies who offer delivery services to do that. You provide adjudication fees. You prohibit adjudication fees and audit fees. You prohibit recoveries outside of the audit bill of rights. Georgia prohibits data mining from PBMs to affiliates, which was passed last year. And you prohibit knowing misrepresentation, as well as the Anti-Steering Act that was passed last year. Something that we would want to bring to the committee's attention is that the anti-steering provisions in 323 have only become effective on January 1 of this year, and so we don't feel like there's been adequate time for that law to be enforced or to have anybody go through an enforcement process after DOI promulgated rules and regs. And so having had company internal processes change to reflect the provisions of the anti-steering law that was passed last year, we would ask for some forbearance to let's see how that law works rather than strengthening it out of the gate. And a lot of what we've heard and some of the examples that you've been shown are for patients that are covered by ERISA plans that are subject to federal regulation, not state regulation. And so, I think just when you look at an example like that and you get a letter from a pharmacy where you don't know the patient's source of coverage, you need to ask that question because it may be something that the state of Georgia can address through a statutory change or regulation with DOI. At this point, Mr. Chairman, I'll change hats and I'll move over to House Bill 947.
Proceed. We'll hold our questions to the end of your testimony.
So 947 is a pharmacy carve-out actuarial study. The Georgia Quality Healthcare Association is opposed to Medicaid managed care carve-outs. We like the current whole person approach to address the Medicaid members' healthcare needs, be it vision, dental, pharmacy, medical, because that is typically what you see in other state arrangements. It allows us to manage the whole patient and to address the risk that is assigned to that patient. Additionally, the plans are all paid a flat per member per month fee for that, and so everything is covered up under that PMPM capitation payment, and the companies are held at risk and have to manage to that in order to drive value for the taxpayer and fund their operations and generate some kind of profit. Carve-out is likelier to cost Medicaid dollars rather than save them. That's true for pharmacy carve-outs, that's true for dental carve-outs, that's true for foster care carve-outs, if you've seen recent fiscal notes on bills that have been introduced in the General Assembly in the recent past. The Georgia Quality Healthcare Association already, in anticipation of this bill, conducted an actuarial study with actual Georgia data. I'll get more into specifics of that in a moment, but it's estimated that it will cost an additional $35 million in total funds to enact a pharmacy carve-out in the first year. The state share of that would be approximately $18 million. So over 10 years, carving in the current arrangement represents a $360 million savings, with $180 million of that savings accruing to the state of Georgia. House Bill 947, by transitioning to the fee-for-service pricing methodology, NADAC, would result in a $90 million windfall for pharmacies that are enrolled in Medicaid through increased dispensing fees. So the pharmacy today is reimbursed on both the ingredient cost and a dispensing fee for each script that goes out of the pharmacy. The average Medicaid managed care dispensing fee today is $1, and we can have a discussion about whether or not that is a fair and appropriate dispensing fee. But the NADAC dispensing fee is $10.63, and so that would represent an automatic increase in the dispensing fee, by a factor of 10. NADAC is also periodically updated. As you heard earlier, it is a national index that has data reported into it voluntarily, I might add. So it's not totally comprehensive, and so it will incrementally increase every 3 to 5 years, and so that will result in additional cost to your Medicaid pharmacy program. And additionally, that rate increase is going to benefit the chain drugstore just as much as the independent pharmacy. So in terms of the access to care for pharmacists, in particularly rural or underserved areas of the state, it's our suggestion that there are better ways to get at that are more targeted and surgical. For example, pass-through payments to sole community providers or pharmacies that can be done and have been done in other states that would be much more of a surgical policy change rather than the broadsword considered under House Bill 947. Again, Georgia has already taken a lead in PBM regulation. I would add, and I would like to read to you a press release from the Georgia Pharmacy Association website that was published January 30th, 2019. The leadership of the Georgia Quality Healthcare Association, representing the companies that serve Georgia's Medicaid managed care members, and the Georgia Pharmacy Association, representing Georgia's pharmacists across all practice settings, are pleased to jointly announce that they have, after much discussion, reached an accord to improve access to pharmacist care by adopting no-spread reimbursement methodologies in future agreements between GQHA members and pharmacy benefit managers. So we listened, we heard that the spread was an issue, and we voluntarily agreed as companies to get away from that practice, at least in the Medicaid managed care program. And that will be complete at the end of this quarter. The final CMO will no longer have a spread reimbursement arrangement with their PBM. In terms of the Line 920 report that you were presented by Chairman Knight, that number was looked at for the previous 2 years. It's been decreasing because spread is coming out of the company's contractual arrangements. In 2020, it'll be less. In 2021, there will be no spread. And so we think that's a positive direction that we're proud that we took in working with our pharmacist partners, because we do need pharmacists, chains, and independents to have statewide access for our members, which is a key requirement of our contracts. Enacting carve-out is not as simple as flipping a switch and moving all those members back over to fee-for-service. It's a heavy administrative lift. It will require additional staff and contracting at the Department of Community Health, and could interfere with the implementation of the Medicaid waivers. And I've seen information that suggests it would be approximately a 12 to 13-month rollout for the project. You've heard a lot about other states that have done this or looked at doing this, West Virginia in particular. To spend a little time on the West Virginia example, the claim is that the report says carve-out program, the report says that the carve-out program would cost the state an additional $2.6 million on drug spending, but that they saved $57 million on administrative costs. The administrative cost savings had nothing to do with the pharmacy program. It was administration costs for the medical side of the capitation payment that they reduced in that year for medical administration through the CMO's contract. They just lumped that into this report by an accident, and then another author in the Lewin Group Lewin Group did that, and then the Navigant report miscalculated that and attributed it to pharmacy savings. The next year, the state had to increase medical administration costs back to the higher level in a subsequent year because of the actuarial soundness requirement for our rates. So there ended up being no savings, and the end result is that the program actually cost an additional $2.6 million in drug costs.
You can move along.
I'm almost done
here.
So again, into the fiscal analysis that we conducted, that's going to come back as a $35.7 million total funds impact in the first year. $17.8 million is the state funds impact. You forfeit $7.7 million in premium tax revenue. But what is the end result of this bill? Currently, under the carve-in model, the pharmacy dispensing fees are $9.321 million. Those would increase to $99.085 million. And additional spending on drugs would be in the neighborhood of $82 million. So a carve-out is something that is going to be beneficial to pharmacists and drug manufacturers, but we suggest that it will not have a positive impact on the state budget, and it will not positively impact the care that's available to Medicaid members. You talk about transparency, but and there's several items in the section 1 of this bill that relate to quality and HEDIS metrics. Moving into, and we're measured on 188 of those that are reportable, and are issued in an annual report that DCH puts out on their website. Moving to a fee-for-service, there are no reported HEDIS or quality metrics. It is an unmanaged program. It is any willing provider, so any pharmacy that wants to take the terms and conditions DCH has and accept the rate can do that, but that is not a way to control cost, and we think that is where the negative impact of the state budget from this would result. And carve-ins, the status quo, they save money by prioritizing generics, and that's really what happens when you see carve-in move to a carve-out state, is that the generic drug dispensing rate goes down and the increase in dispensing on more expensive brand name drugs goes up. And that is why this is not something that states have been able to employ in a widespread fashion as a cost savings measure. So I'll cut off my remarks right there, Mr. Chairman.
Thank you. Just a follow-up question to something I had asked earlier. regarding the fines that were in place for the steering from last year's bill, which was fully vetted and addressed by the industry. And we've seen some evidence today that it appears that could still be going on even in 2020. Are you aware of anyone being fined for this at this time?
I'm not aware of any enforcement action that's taken place so far. And what I would suggest is that that example of steering may be related to a federally regulated product.
All right. This time, committee members, who has a question for this presenter? Chairman Knight.
Thank you, Mr. Chairman. To my old friend. We go back a long ways when he was just coming out of school. So I thought I trained him better than this.
Must have gone wrong somewhere, Mr. Chairman.
He is a good guy, no matter what side of the position that we're on here. I will vouch for him and his character. All seriousness joking, I think what we're seeing and where we've come to, and especially with the open records and the contracts that we've got that are redacted. And I don't dare speak for everyone in the General Assembly, but I know I've heard this sentiment. Quite frankly, as an old auditor, that old adage of trust but verify. Quite frankly, I think a lot of that trust has gone out the door. You and I had talked about in a hearing, I think it was one of Chairman Hawkins' hearings over the interim, we talked about the issue of steering. And it was, hey, we've done. But that letter was 2 years ago. Okay? So it's gone on for 2 years and lagged for 2 years. And again, that was not an agreement. The lobbyists can make all the agreements they want, but the agreement is with the state. And I want to make sure we say that clearly. And in those 2 years since we've sent here and seen since that first report, $93 million. And I would dare say in today's budget times, with the issues that we're seeing in Georgia right now, $93 million that we could have put back into health care and the other areas of the state of Georgia would be sorely needed right now. But instead, that went into the pockets and the profit of the companies. So I'll end there. In regards to the study, we've said from the beginning, we tried to get DCH to do this, and I'm sure you were aware of this back in the fall. We want third-party objective studies. Not sure how your association got all of the data and the permission from Department of Community Health to do these studies, but I would dare say that this General Assembly will want a third-party, completely independent study. There's bouncing both sides of the aisle out there, and I've seen the bouncing back and forth of the reports, and it's only natural that your industry would do that. In fact, some of the conversation was to get the pharmacy industry to do the report, and we did not go for that because it was not independent. And I think that's what this body is looking for, is true independent data. And we're tired of the OPEC, contracts and nobody being able to see behind the curtain. And I think that's what we're going for. So I'll leave it at that.
Thank you,
and
Chairman.
I appreciate you. I've known you for a long time. I'll attest to your character and that. I just thought I'd raised you better than that.
Chairman Nix.
Yes, thank you. Can I address something that Chairman Knight
Sure.
raised? What I would say and should have said in my remarks is that we welcome the study. We think we'll be vindicated by an independent, well-articulated and executed study that avoids some of the issues that happened in West Virginia where there was a misconstruction of the savings, or in Kentucky where there were just errors that went into the report. So we welcome the study. In terms of House Bill 947, if that was just Part A of Section 2, I wouldn't be up here to oppose that bill. But Section 1, with all the legislative findings and the trigger mechanism where the legislature is delegating its legislative authority to a third-party auditor, is what gives us pause and concern. By all means, conduct a study. I understand there'll be money put in the budget for that. And we welcome that scrutiny because we do think that we will be vindicated.
Chairman Nix, sorry.
My turn? Okay, thank you, Mr. Chairman. A couple of quick questions, and this is going to be much more simplistic. when we see the examples that the local pharmacist is reimbursed $40 and the referred pharmacist is reimbursed $400, do you agree that that actually happens, or you deny that?
I mean, I'm not going to argue, Chairman Nix, I will not argue with the example that you have there. What I would caution you is that, you don't know the source of coverage for that patient necessarily in all the examples. Perhaps in that example that you're referring to, there was a source of coverage, but you have to look at the totality of the scripts and the total aggregate payments and the total number of scripts to really judge what the total reimbursement level would be, rather than just looking at a single example. You have millions of scripts and millions of patients.
And if I may follow up,
Certainly.
the other part of that question is this. You talked about transparency for other groups, buying groups, I don't know who all you mentioned. If that indeed is true, that there's that big a difference possibly in the price differential, then why is that there? Why is there that huge a difference between the $40 and the $400? Is somebody much better at buying? Are they getting much better deals? Is that what you're trying to say by transparency with other people? Or what would that reason be, please?
So that could be potentially for a number of reasons. So the list price of a drug is unilaterally set by the manufacturer at the factory gate, and they have monopoly, over brand name drugs for the duration of the intellectual property on that drug. Then it goes to a wholesaler and distributor, who, as I mentioned, also have direct ownership relationships with the pharmacy services administrative organizations, which do a lot of back office type work for both chains and independent pharmacies and groups of independent pharmacies. There's also group purchasing organizations who negotiate the acquisition cost of the drugs to the retail pharmacy from that wholesaler distributor. And there's provisions in those contracts, for example, whereby that pharmacy is locked into that GPO. So even though they may be able to get a good price, say they have 100, simple example, they have 100 drugs that they're purchasing from that GPO, they have to purchase all 100. They can't shop to get a better acquisition cost from a different GPO because they're locked into that group. Then the PBM comes in and negotiates the end result that the health plan would then pay, either as the plan sponsor or on a commercially underwritten plan. And then the pharmacy has could potentially have a markup on a drug as well, like most retailers would have a markup on any other product besides a pharmaceutical agent. So that's kind of the whole ambit of my remarks, is that there are so many different entities that touch and affect the price of this as it goes through the chain. Just focusing on the interaction between the PBM and the pharmacy, you're going to miss a lot of those interactions and the potential to potentially either increase transparency or help control costs.
Okay, thank you. I don't know that I can understand that at all. In economics, I thought the more you buy, usually the lower price you get, and if you're PBM, you're buying a lot more than the other people are. So that does not make economic sense in any way to me. And I'm a simple person, so I don't get that.
Well,
Thank you.
This will make your eyes cross very quickly, absolutely.
Well, this doesn't have anything to do about the price of drugs, but you said something that caught my attention. And we've already had our authority taken away one time recently. When this bill did you said something about something in this bill gave the legislator's authority to somebody else?
In the carve-out bill, Madam Chair, you're setting up to where if the study shows a specific amount of savings in the carve-out.
Where is that in
it's
the
in Section 2. I believe it's in subsection B.
Because we've already had our powers taken away one other time.
Subsection B, it is line 112 and 113. So again, if we welcome a study, if DCH is able to do that and hire an independent third party and it shows that it's going to save a boatload of money, then you guys are going to come back and pass a carve-out bill next year, and there really won't be much that we can say to do so. But you're delegating to a third party the ability for this statute to be enacted. What we would also ask is that $20 million threshold is a minuscule amount in terms of Medicaid funding. It sounds, that's a lot of money to almost anybody, but they've probably spent $20 million while we've been in this hearing today. And the state-funded savings for $20 million is approximately $5.7 million, which is, again, a very, very disruptive change to make to $500 million in drug spending and 1.2 million patients pharmaceutical care for $5.7 million savings, which is a rounding error in Medicaid terms. We would ask that if this bill moves forward, that threshold be dramatically increased to something that's meaningful in terms of a percentage point basis of Medicaid spend.
Chairman Cooper.
Jesse, and I can call you that since I think you probably started with me as an intern.
Yes, ma'am.
You sort of threw a bunch of people under the bus when you first started saying, you know, why should it just be us? It should be all this 1, 2, 3, 4, and 5 groups of people I've ever heard about. Well, if they're so willing to work together with us, why didn't they come to us and say we're willing to work and ask for meetings? For the first time ever this afternoon, I had one group, and they said there might be another group, that, and it's about PBMs, say, could we hold off on these 2 bills that you're discussing and maybe get together, you know, before they pass and still move them before they go out so we can discuss it, so we can work out the differences. But I don't believe, and they haven't come to me to ask for a get-together. So I don't need an answer. I just think that if they were so willing to do something, we would have been asked for a working group to try to work this out ahead of time.
Thank you, Chairman. Thank you, Mr. Wethington.
Thank you, Mr. Chairman, members of the committee.
Right now, Scott Woods. And let us know which bill you're speaking about.
Great. Thank you, Mr. Chairman, members of the committee. My name is Scott Woods, and I'm with the Pharmaceutical Care Management Association, the National Trade Association for Pharmacy Benefit Managers.
5 minutes, please.
Yes, and I'm going to speak on both House Bills 946 and 918. PBMs administer prescription drug benefits for more than 8.8 million Georgians who receive their health benefits through their employer, the individual insurance market, Medicare, Medicaid, and TRICARE. Every day, PBMs are negotiating with drug companies to lower out-of-control prescription drug costs, to drive competition for more generic medications, and secure rebates and discounts for those 8.8 million Georgians. They're fighting to lower the cost patients pay for the medicines that they need. This is an important job, and we need every tool at our disposal to drive the savings that go directly to Georgia employers and consumers. PBMs are also an important part of a coordinated patient care, healthcare ecosystem that's focused on improving health outcomes. PBMs employ doctors and nurses, pharmacists, social workers, care coordinators, and others to ensure that patients don't have an adverse drug event, they're being adherent to their medications, and that they're managing their opioid use, among other things. PBM clients trust us with not only their dollars, but also with their employees' and members' well-being, and that's a responsibility that our member companies take seriously. We've heard that the goals of House Bill 946 are threefold. First, to provide more predictability for pharmacists. Second, to provide more transparency. And third, to lower drug prices. Unfortunately, the bill doesn't accomplish much for those 8.8 million Georgians that have their health care benefits administered by a PBM. I'm here today before the committee in the General Assembly, and our member companies are committed to the process of improving this bill. We welcome the opportunity, which we have not been afforded so far, to work with the sponsor and stakeholders to develop a truly patient-centered bill. First, I want to say that the scope of the bill, I think there's some question about it, could affect every single health plan in the state. But what I heard earlier from Chairman Knight is that to the extent that the bill would conflict with federal law, that federal law would control. Now, if that's the case, a number of the examples potentially are things that exist under ERISA-controlled plans, and then federal law would control. So to the extent that there might be complaints that are being given to the Department of Insurance, those could be under ERISA plans and would not be considered under 233, 323, or perhaps House Bill 946. But I think that there is some question there as to what the applicability is. I think in noting the time restriction here, I just want to highlight a few of our major concerns with the bill. I think that some of the provisions would really impair our ability to drive value and improving patient care in the system if pharmacies can't be held to performance-based contracts or value-based purchasing arrangements. Prohibiting so-called point-of-sale fees and retroactive fees, first of all, mischaracterizes what these assessments are. And are typical, too, in performance-based contracts. They're designed to hold pharmacies accountable for the agreed-upon value-based benchmarks, such as generic dispensing, opioid dispensing oversight, patient adherence rate, and prescription refill rates. These are important measurements to ensure high-quality care at the pharmacy counter. Performance-based contracts are commonly used for all providers in all parts of the healthcare system, but House Bill 946 would create special rules for pharmacies, which will only cause to serve to decrease quality and raise costs for Georgia patients. House Bill 946 tries to inject transparency into the healthcare system by imposing, a one-size-fits-all government mandate on insurers and employers in the private marketplace by requiring certain contract terms, such as a 100% rebate pass-through and prohibiting spread pricing. PBM's already passed through an average of 90% of manufacturer rebates to plan sponsors, which are used to reduce premiums for everyone. Spread pricing is a contract option that many employers may use to provide predictability in their budgeting, and that choice should be theirs to make, not the General Assembly. I want to say that to echo what Jesse said earlier, that the PBM industry is not opposed to transparency.
Try to, as soon as you can, we had several waiting. I just wanted you said you're echoing Jesse. Just see if we can bring it to a conclusion, if you don't mind. I appreciate your testimony.
Thank you. I do want to say that it is important that we have a transparency bill that includes all of the parts of the supply chain. We shouldn't just focus on one part of the pie. And that's not to point fingers, that's not to obfuscate, that's not to say that PBMs don't have a role, an important role in the healthcare system, but manufacturers set the prices of their drugs. Nothing in 946 addresses drug manufacturers. There's nothing about pharmacy transparency. That's an important part of the pie. And to say and to dismiss the role of pharmacy services administrative organizations is to miss a giant part of what pharmacies are encountering when they're locked into contracts and then they say and they can't purchase most efficiently. Then we're saying we should sort of drive up spending in the system because they're locked into those contracts. That does nothing for patients. I don't know if you want me to, Mr. Chairman, to switch over to House Bill 918 with my remaining time, or if you would prefer to stay on 946.
You can do it in a couple of minutes, that's fine.
Okay. I just want to say that we've worked really well with Chairman Cooper over the years, especially on the step therapy bill that you passed last year, which I think was an important patient protection bill that covered patients switching health plans and not having to go through step therapy. So I think we're willing to come and talk public policy and what's going to work best for Georgians. Great, thank you, Madam Chair. I will say that pharmacy audits are a critical tool used by PBMs not to make life more difficult for pharmacists because it does take time. It's expensive. It's an important part of their business, and we don't want to take their time unnecessarily. But it's also clients' dollars. It's also patients' dollars that are on the line as well. So to the extent that we can tighten and we can ensure that we're not going to have fraud, waste, and abuse in the system, while also ensuring that we can find reasonable ways to ensure that patient dollars aren't going to be at risk, we should do that. With regard to the referrals, and Chairman Cooper, you had mentioned very passionately about oncology. I think we've got some language that we're prepared to help improve the bill, and I think that that accomplishes your goal of wanting to ensure that patients can get immediate access at the provider level. If there is medication that's available in the physician's office that's covered by their plan, and that initial fill, I think we can find some ways to work together on that piece. Thank you, Mr. Chairman.
Representative Perkle.
Thank you, Mr. Chairman. Mr. Woods, it took great courage to stand up here after we read the bill, and I thank you for that. Regarding your priorities, if one of your priorities is to fight to lower costs, you have failed miserably. Improve health outcomes. We saw, the 3 weeks for a child to get critical medicine. Failure. Trust us. I've got several friends. One is an independent pharmacist, and he is a brother in Christ. And if I even say PBM, he curses at me. And for the ERISA, so this is perhaps not, this could be an ERISA plan, not a state managed plan. The argument that you can't prove I'm robbing you because I'm busy robbing your neighbor. What we saw with the letter that Chairman Knight put on the board that says, you cannot go here. If you go here, you will. I can't tell you not to see this pharmacist, but if you do, you will pay 100%. Whether that's ERISA, whether that's the state, that is just wrong, in my opinion. I am hopeful that in the bills that we have looked at today, that it might not be just right, but I've got to tell you what we're doing is not working. So I'm sorry if that was just a comment, but our question be tough to respond.
Thank you. Chairman Knight, briefly.
Thank you, Mr. Chairman. Scott, thank you for being here today. I know this is a tough issue, and you've got a tough job. But Mr. Weatherington indicated that drug costs were going up by 58%, I think, from 13 to 17. But in the same breath, you're saying that's lowering cost, right? Or how does that sound like it's lowering cost? I'm not sure. I mean, if it's going up that much and by 58%, and y'all are saying you're lowering cost,
Right.
That's just on its face, opposing facts.
And I can understand, Chairman Knight, the question. Drug manufacturers set the prices of their products, so he's not incorrect to say that prices have gone up by 58%. But if you look at the trend reports for what our member companies report to their clients, in some cases the drug trend is going up by low single digits. In some cases it's actually going down. So that's basically saying that a PBM client, whether it's a health plan or employer, actually saw their prescription drug spend less in 1 year than it was in the prior year. And that's because of all the tools that PBMs have at their disposal and setting up networks, all of the things that would be harder, frankly, to do in 946, and setting up networks and utilization management, all of those things that help us to bring down the cost of the drug and ensuring that we have as strong a hand in negotiating not only with drug manufacturers, but with pharmacies, with all due respect, Mr. Chairman, to bring that into parity.
This body will take up those other issues. We've got to start first with the architect of the prescription drug benefit plan, which is the PBMs. But two things, you talk about data and all that. Well, we can't get to it, or we can't get to what you show your clients. But my last question, and I know we've got other presenters, but I'd ask, who are your biggest members and what were their profits in these same years?
So PCMA, I should say, first of all, PCMA represents about 18
Could you just give us the top three?
So in terms of our top three, I can't speak to, in terms of market share, nor, and PCMA, I should say, because of state and federal antitrust laws, are not privy to the data that would, that I think you're trying to get at in terms of market share or any of that. That's just not something we have available to us.
I can answer that question for you, Scott. And again, it was a rhetorical question. It's all in the publicly traded companies. It's all in Security and Exchange, filings. But if you know, I would dare say Express Scripts, CVS, Optum. So, you know, all those, you know, the data's in there. And again, that's the story that's not being told is you say we're saving cost, but at the same time, where everyone's cost is going up, the premiums, the copays, the deductibles, at the same time, the cost or the profits that are being seen by these companies are exponentially going up. And again, if we're going to be intellectually honest about this, we've got to make that part of the conversation.
Thank you,
So,
Chairman
again,
Knight.
I appreciate it.
Chairman Corbett.
Thank you, Mr. Chairman. My friend from Ocilla, you know, anyway, he stated it much better than I can, but I wrote down basically the same thing he put down about PBMs. The previous speaker said control cost. I think a present speaker said lower cost for the 8.8 million Georgians, trust factor, the ERISA, and the plans. But I'd just like to give you a real world example that's in my district that I've met with Chairman Knight on last week. I had a constituent call me, a 67-year-old gentleman, insurance company. The company would change to a new company. He was getting his diabetic medicine at a Walgreens, and with rebates, he was getting it for $0. They changed companies. He said, no, you can no longer go to Walgreens. You've got to go to CVS. You've got to get a 90-day supply, and now his out-of-pocket expense is $2,000 every 3 months. Real person I'm talking about. So in my district, so I experienced that. So if we're controlling costs, I agree with my friend, Representative Perkle. We're doing a bad job.
Thank you for your presentation, sir.
Thank you.
Thank you. Thank you, Chairman. Okay, if Josh Golden, once again, if we can try to make it as concise. I know there's some important information, but please.
Thank you, Mr. Chairman, members of the committee. I'll try to keep these comments brief.
Thank you.
My name is Josh Golden. I am Senior Vice President of Strategy with Capital RX. If you'll permit me, I'd like to just take a minute and explain my background, which may help to explain why I'm standing here in the first place. I spent the last 20 years as a consultant to some of the largest health plan sponsors in the United States. This includes Fortune 500 companies, labor unions, government entities, state municipalities, state government programs, et cetera. I helped them navigate the often murky waters of the pharmacy benefit landscape. So I helped with managed procurement processes to help them select PBMs. I helped them negotiate PBM contracts, help them implement with PBMs, and ultimately help them audit PBMs after they were implemented. I only explain this because it provided me with a pretty unique window into the inner workings of the typical PBM business model. Respectfully, I would argue there's probably a few dozen people in the United States that could accurately describe how PBMs make money and would be willing to stand up and speak publicly about it. I happen to be one of those people, and so I just wanted to offer up my perspectives and my expertise as you all work hard to deliberate this extremely important piece of legislation. So about my company, Capital RX is technically a PBM, but we are by no means a typical PBM. We stand here today in support of House Bill 946. Our company is based on a simple principle, and that is that in order for a PBM to act in the best interests of patients and plan sponsors, the relationship must be both aligned and transparent. And now when I talk about alignment, it's pretty simple. There should be no conflict of interest in the PBM's business model. When I talk about transparency, and that word is often, sort of bantered about in this industry, my definition is pretty simple. Every drug should have a price. That price should be the same for everyone that's involved in the transaction, and it should be easy to validate. Now, unfortunately, the vast majority of PBMs in the industry are neither aligned or transparent. Most of them derive profit from a vast array of complex and opaque financial arrangements that extend up and down the supply chain. It would take me about an hour to go into all the details of those types of arrangements. I'd be happy to do so, but I know we don't really have time for that today. But I think that some of the speakers have touched on some of the most significant sources of indirect profitability that PBMs enjoy. They use proprietary price lists, which are often called MAC lists, maximum allowable cost lists, to manipulate the price of drugs within the retail environment, extracting margin and profitability with a high level of precision. They steer patients towards profitable dispensing assets like mail order pharmacies, specialty pharmacies, even when those patients might be able to obtain those same therapies at a lower cost elsewhere. And they quietly retain hundreds of millions of dollars in rebates from pharmaceutical companies. Thankfully, the media and forward-thinking government officials such as yourselves are starting to shine a light into the black box of the PBM business model. Capital RX may be the only PBM that's willing to stand up and say, yes, let's shine that light as bright as we can. Let's explore the PBM business model. Let's unearth it. Let's identify those aspects within it that represent a conflict of interest to the plan sponsor or the patient, or that impede the free market competition of drug prices within the U.S. And to the extent that we find aspects of the business model that do that, let's get rid of them. Let's replace them with mechanisms that support free market capitalism, free market price competition, and that align the interests of the PBMs with the folks they're supposed to be representing and working for. I wanted to applaud the authors of this particular legislation, HB 946, in general, for the efforts that they're making now to increase transparency in the industry. But I wanted to call out, if I may, a couple of aspects of the bill that we're particularly supportive of as an organization. Again, this makes us a bit of a unique animal within the PBM industry, but this is what we stand for as an organization. Number one, that a plan sponsor should be charged the same price that a pharmacy is reimbursed. This to me is simple. It's at the heart of our business model as a PBM. Anything short of that simple truth, anything short of that is going to allow the PBM to act as a price manipulator within the supply chain. And once they're in that position of power, they can extract margin. It's as simple as that. Just as simple as the notion of passing through 100% of rebates. Mr. Woods, one of the prior presenters here, mentioned that PBMs pass through a portion of rebates, 90%, and that they retain in general about 10%. I would argue with that statistic. I think a lot of that boils down to how you define rebates. When we casually refer to rebates, those are actually a myriad of revenue streams. I'm not going to get into the details, but they extend far beyond rebates at this point and include other revenue streams that are largely retained by the PBM, again, quietly and without, in many cases, without the awareness of the patient or the plan sponsor. So the argument is always made, I think, by the traditional PBMs, well, okay, so what? If that's how we make money to support our business model, it allows us to charge a lower administrative fee to the plan sponsor. And while that may be true, I would argue that the moment a PBM begins to retain rebate dollars as profitability, then they have entered into an area of conflict of interest. Those are conflict dollars. And I'll use an example to explain how this can play out within the real world. For the best example of this, we really need to look no further than a drug called Duexis. It is a drug that is a brand name patent-protected drug. It was released a few years ago. I'm seeing some nods in the audience. I bet that you may start to hear the collective groan of a few pharmacists who know what this drug is. It is comprised of two active ingredients, both of which are available in OTC form. It is basically Pepsid AC plus Advil. Merged together into a single pill for convenience, slap a new color on it, and the price of that drug, if anyone wants to guess, I don't have the AWP handy, it is north of $2,000 for that prescription. Now, I heard both Mr. Wethington and Mr. Woods say in one form or fashion that PBMs exist to address the rising cost of pharmaceuticals. And I certainly applaud that. But if a PBM's job is to help their clients manage pharmaceutical costs, what PBM in their right mind would promote a drug like Duexis over the widely available over-the-counter alternatives that cost together $20 a month? Well, you may be surprised to learn that most large national PBMs have at one time or another included Duexis on their formulary, actively steering patients towards this product. And why do they do this? Well, because Duexis, with its price tag north of $2,000, also has a rebate on the back end. Now, we don't know what this rebate is because that's subject to the veil of secrecy that PBMs maintain over rebates. But we do have a guess. We think it's somewhere in the neighborhood of 70–80% of the drug cost. And of course, the PBM is permitted to retain a portion of that rebate. The end result is that and by the way, this is just one example of a product that I would consider to be waste in the system that could easily be eradicated if incentives were better aligned. The end result is that plan sponsors and taxpayers are paying billions of dollars for these and other wasteful products every year at the encouragement of the PBM, who's actively steering patients towards these products because they have a profit stake in the outcome. I will mention steering because we as an organization also agree that it is a conflict of interest for a PBM to own a dispensing asset and actively steer members, patients towards that dispensing asset for profit. In my mind, and in the mind of our organization, I think many like-minded individuals here, vendors need to decide what they want to do. Do they want to serve the best interests of plan sponsors and help them manage cost and help them manage health outcomes? Or do they want to profit off of the dispensing of expensive pharmaceutical products? I think you could do either of these things without an inherent conflict of interest. But the moment you attempt to do both of those things simultaneously, the conflict is obvious and it's inevitable. I wanted to call out again, if you'll permit me 1 or 2 more moments, I wanted to call out the use of NADAC as a reference benchmark for pricing. I know that the bill has experienced some changes as it relates to this particular provision, but I did want to applaud in general the movement towards NADAC as a more rational index for monitoring, tracking, and benchmarking drug prices. We believe very strongly in this. There are many PBMs out there who would argue that this can't be done, that AWP, average wholesale price, and MAC lists that they manage is the way it's always been done, and that's the way it always needs to be done, that's the only plausible way of managing drug cost. We've got news for you. Capital RX last year recontracted our entire retail network using a NADAC reimbursement model, similar to many state Medicaid programs. So to those that say it can't be done, we've got over 60,000 retail pharmacies in our network that would argue otherwise. Some comments were made about NADAC that I want to just touch on briefly. Mr. Wethington mentioned that, under NADAC, dispensing fees are higher, and I will acknowledge that. A dispensing fee under a typical PBM arrangement using AWP is somewhere in the neighborhood of $1, $1.50. Now again, I'm not a dispensing pharmacist, but I know that there are a few in the room. I would look to them to ask whether they feel that that's an appropriate reimbursement for the service of preparing the prescription, dispensing it, and advising or guiding the patient. Obviously, we know that is a subsidized fee. That fee is subsidized by some unknown margin that's built into ingredient cost. So yes, under a NADAC reimbursement, the dispensing fee is higher, but the ingredient cost reimbursement is far lower, and the total cost ends up being lower in the aggregate. And we have results that can prove that across our 46 clients that have joined our organization. Now, Mr. Wethington also suggested that we extend transparency, this notion of transparency, up and down the supply chain to include other players. And I think we agree. A NADAC reimbursement model would effectively do this for retail pharmacies because it gets their dispensing costs out on the table where we can understand what it is and then begin to negotiate towards the lowest net cost. Now, I've got a number of other elements I'd be happy to talk about, but I probably should pause here because I've been speaking for quite a while, and I guess I'll defer to the committee on any questions at this point.
We do. Are any questions from the committee members at this point? If there is a quick summary you want to give, that'd be fine, or if you're at a good stopping point.
I will only say again that I applaud the authors of the bill for bringing about this important issue, bringing it to light. Again, kudos to the committee and the House as a whole for considering this. We are highly supportive of this legislation. We are proof positive that a aligned PBM business model can work and can drive outcomes for patients and plan sponsors. I will say that for those plans, to the point that was made around a transparent PBM model potentially increasing costs For plan sponsors and patients, we have anecdotal evidence otherwise of the clients that have moved to our transparent platform. They have experienced savings of approximately 13% year over year from their prior traditional PBM model. So I'd be happy to share that evidence with anyone that's interested. But again, thank you very much for the opportunity to share my thoughts, Mr. Chairman.
Thank you for your contributions. I know we had that's all, thank you.
Yeah.
I know Chairman Corbett mentioned a constituent with a real-world issue, and I think we'd like to go on now to a couple of people to speak maybe from the patient perspective. Heather Breeden, are you here, if you don't mind? Thank you for joining us, and thank you for bringing this. We are on a time schedule, so thank you for your...
Good evening. Thank you for this opportunity. My name is Heather Breeden. My testimony is on behalf of the National Multiple Sclerosis Society. I serve as a senior manager of advocacy in 3 states for the society, and I reside in Sandy Springs. Thank you for the opportunity to share our support for HB 946 and HB 947, which are meaningful for Georgians living with multiple sclerosis. It is important to note that the Society looks forward to the Supreme Court's decision in June regarding ERISA plans and the ability of states to regulate PBMs. As we discuss access to prescription drugs, it is important to note that less than 5% of the Society's annual revenues come from pharmaceutical companies. We do not take any corporate funding tied to our advocacy issues or outcomes. Multiple sclerosis is a disease of the central nervous system characterized by inflammation, demyelination, and degenerative changes. Symptoms vary by individual and range from numbness or tingling to walking difficulties, fatigue, dizziness, pain, depression, blindness, and paralysis, as well as cognitive dysfunction. People with MS may experience relapses and remissions of neurological symptoms. Nearly 1 million people in the United States live with MS. That is twice the number that we thought just a couple of years ago. Experts in MS strongly recommend treatment with the disease-modifying therapy to be initiated as soon as after a diagnosis of MS is possible, and treatment should not be delayed or interrupted unless there is a clinical reason to do so. The median price for DMTs continues to increase. In 2019, it was $88,853. A recent study showed that MS DMT cost nearly tripled over the last 7 years. More than half of the people with MS are very concerned about being able to afford their DMT in coming years. The 88,000 number is just for a disease-modifying therapy. It does not consider the cost of other often used medications used to control and treat MS symptoms and comorbidities. The rising cost of drugs and insurance coverage changes favorable to insurers disproportionately affects people with MS, causing delays and disruptions in treatment. Within your folder, you have the testimony from Christine Werner. Christine is chair of the Government Relations Advisory Committee here in Georgia for the MS Society. Unfortunately, Christine had a very bad MS flare today, and she could not be with us. I encourage you to look at her story within your folders. Approximately 20 different DMTs can currently be used to treat MS, and unfortunately, they are not interchangeable. 40% of people with MS alter or stop taking their disease-modifying treatments due to cost. Over the past 3 sessions in my role with the National MS Society, I have watched numerous individuals with MS face delays accessing their medications, along with devastating medical bills for drug infusions and forced steering to mail-order pharmacies owned by PBMs. I have also been with individuals living with MS as they absorbed the shocking news that patient assistance funds from drug manufacturers could no longer be used toward deductibles and their out-of-pocket maximums. Specifically, we support HB 946 because It mandates that PBMs charge health insurers the same price for a drug as it receives from the drug manufacturer, and that PBMs pass all rebates from the manufacturer to the health plan. Also, it disallows PBMs from building drug formularies in a way that discriminates against people with prescription drug needs. It strengthens the Georgia Insurance Commissioner's ability to hold PBMs accountable to state laws and regulations, and it requires PBMs to apply any third-party payment, financial assistance, discount, product voucher, or other reduction in out-of-pocket expenses made by or on behalf of an insured toward an insured's cost share or copay responsibility. Finally, we also support HB 947. Please require the Department of Community Health to engage an independent actuary to conduct an actuarial study of the fiscal impact of carving out pharmacy benefits from the state's current Medicaid care management organizations. In states including West Virginia, Arkansas, Ohio, Nevada, and Louisiana, the Society has successfully worked to ensure that care management organizations and PBMs do not profit from spread pricing and state supplemental rebates due to some of the state's poorest citizens living with MS. We are grateful for the opportunity to testify on these issues, which are very important to all Georgians living with multiple sclerosis.
Thank you. Thank you for your testimony today and for being here. Anna Adams. Thank you for being here.
Yeah, thank you, Mr. Chairman. Good afternoon. I am Anna Adams with the Georgia Hospital Association. I have had the pleasure of working with many of you over the years on hospital and healthcare related issues. And I'd like to start by saying that from a hospital standpoint, we are very much, as an industry, supportive of measures that make sure that patients have access to their medications. Today, however, I would like to talk to you about a more personal issue with medications. I serve on the Activism Advisory Council at the national level for the National MS Society. And every year, access to medications is one of the top priorities for people who are multiple sclerosis patients. Access to medications can include things like affordability of drugs, access to drugs, cost transparency, and as you just heard from Ms. Breeden, cost of drugs is one of the biggest issues when you're dealing with multiple sclerosis because all of these medications are incredibly expensive. Section 6 of this bill is the section I'd particularly like to talk to you about. This section is addressing copay accumulators, and I care about this section from a personal standpoint because I have multiple sclerosis. Every year, the cost of my disease-modifying therapies reaches close to $200,000. I would like to let you know that I have excellent health insurance, and because I am a responsible healthcare consumer, I have the lowest deductible possible, I have the lowest out-of-pocket max possible, and I pay high premiums to ensure that I am covered because I understand that this is a very expensive disease to treat. Last year, I started getting bills for my health care related to the monthly infusions that I go and have to keep my MS in check. Those bills were the result of my insurance company initiating copay accumulators. This means that the drug discount program, the drug rebates that were formerly taking care of my deductible and my out-of-pocket max were no longer applying in those scenarios. And this all happened without any notice to me. Again, as a responsible healthcare consumer, I have a flexible spending account that I put money in at the beginning of every year to make sure that I can cover my healthcare costs. But that money is money that I could be using to save for my children's college education. It's money that I could be putting in my 401k. And some of the people that spoke earlier were alluding that potentially these issues were coming from plans that were ERISA plans. I can tell you that I do not have an ERISA plan. I do not have a state plan. These These practices that are being implemented by the insurers are harmful to patients, and they put patients in a situation where they cannot get access to their medications in the way that they're supposed to take them, and every time something like that happens, an MS patient risks relapse. Relapse from an MS standpoint means that your immune system is going to attack your brain and your central nervous system in a way that could potentially harm you for the rest of your life. If I have a relapse, I could be in a wheelchair. So it is very important that MS patients stay on their medication, and things like copay accumulators stand in the way of patients being able to do that. So I would like to thank Chairman Knight for including this section in this bill. It means a lot to me as a patient. And you know, from a hospital standpoint, as I mentioned earlier, we care that patients have access to their medications. So thank you for hearing me. I'm happy to answer any questions.
Thank you so much for sharing with us today. That's very moving, and thank you for being willing to share personal. Alan Hayes is next. Alan?
I'm Alan Hayes. I represent America's Health Insurance Plans, which is a National Association of Health Insurance Plans, obviously. I'd like to say from the outset, I also applaud Chairman Knight, because this is obviously an issue of great concern to not just Georgians, but to Americans in general. And I jotted down before I walked up here. I would like just to remind everybody that without health insurance, most Georgians couldn't afford health care. So while you're working on further regulating some of this, some of these that affect the price of insurance, I would hope you keep that somewhat in mind. And I would also say that one of the previous speakers from the PBM, I think that's just a great example of how when there's a free market, that individual companies or individuals can come up with ways to improve a product or market a product and then find clients. I would say that from a health care standpoint, why do we care about PBM prices or PBM issues? 23 cents of every healthcare dollar now goes to paying pharmaceutical costs, drug costs. I started representing AHIP 10 years ago. That was 15. So it went from 15 to 23 in 10 years. And you as pharmacists, you all know that the price of drugs are going up at a rate far exceeding inflation, and have for years. And so that is why we are very concerned as health plans. And as health plans, one of the strategies we use is we use PBMs to help negotiate prices for us. I'm not going to go back over how complicated this system is. I think you all appreciate that, and no one more than Chairman Knight does. It's really an understatement to say that this is a complicated economic ecosystem. But the truth is that drug prices have been skyrocketing for many years. Drug companies control those prices, and only those companies can lower them for Americans. But instead, year after year, they raise them, and sometimes multiple times in a year, prices are raised. So health insurance providers try to negotiate with drug makers for lower net prices, and we do this often through a PBM. And then we pass those savings on in the form of lower premiums and lower out-of-pocket costs to all consumers. But only the drug makers set the price of the drug. Since drug costs have exploded over the years, and again, PBMs are fairly new to the health insurance and the health care world. Over the years, health insurance companies, self-funded ERISA plans, government plans, have all relied more on PBMs to control drug costs. And we know that PBMs bring value through lower costs for insurers. They negotiate with pharmacies and drug manufacturers for discounts and then pass those discounts on to other companies. And you don't have to take my word for it, or anybody else who stands here. The Federal Trade Commission, the Congressional Budget Office, the Government Accountability Office, the Health and Human Services Office of Inspector General, and most recently the Kentucky Teachers Retirement System have all produced research showing PBMs lower health costs. If they didn't, lower health costs. Health insurance plans, self-funded ERISA plans, they're big corporate entities, government plans like DCH and State Health Benefit Plan, they would not contract with them for their services. So as you're, again, proceeding through this process, and as others have mentioned before, there's room for improvement in the PBM arena, as there are, again, and we will echo the sentiment of some who've come up here, and we've shared this with many of the committee, that we'd like to see this a broader approach to this whole economic system. That transparency is probably good in the whole system, and we've been suggesting that you look to a bill that Texas passed last year when it comes to transparency, that required the transparency on the part of health plans, who I represent, transparency on the part of PBMs, which you're covering here, and then the transparency also on the part of the drug manufacturers to actually set the price. And I would say, you know, again, I know you got not much time left, so I will just say I look forward, Chairwoman Cooper, to working with you on copay. I think I have a lot of information on that issue. You know, one of the things that strikes me, again, drugs are expensive because that's what the drug company prices them at. They price them very high. So then to give you a coupon instead of lowering the cost, it doesn't make much sense to me. Why don't they just lower the cost? They could lower the cost, or they could give it to you for free. So obviously, and you probably have heard this from me before, but copay coupons are a way to circumvent a system of trying to get people to switch to a generic when there's a generic available, instead of the brand name expensive drug. And so while there probably could be a lot of improvement there, and you would know better than me, I want to be able to protect some of that, make sure we still are able to encourage members to go to the generic, the cheaper alternative.
You did mention, if you don't mind, that drug manufacturers set the cost.
Yes.
I'm not sure if the cost passed on to the health plan, it says it's $2,000, but the PBM is getting a 50 or 60% rebate. What number do you consider the cost?
Well, the price, all negotiations, and again, that's a negotiation between two fairly sophisticated entities, a drug manufacturer and a PBM, or a drug manufacturer and a wholesaler. Just
you
like,
like to know
again,
about
these contracts between PBMs, their clients are government agencies, or big ERISA plans, they're big Fortune 500 companies, or health plans. They're not pulling the wool over anybody's eyes here. These are sophisticated buyers that know what they're getting into, and to the extent they can contract and write these things in the contract for whatever their particular need is, they do that. So every contract is surely different, and I would say that to the extent you can allow the market to work and allow PBMs or others that are trying to lower drug costs to have as many tools as possible, would be the best way to go. Did I answer your question? I got lost in my own answer, so.
I'm still trying to figure out whether it's $2,000 or $800. But anyway, go ahead, Chairman Knight.
Thank you, Mr. Chairman. Alan, thank you for being here. And again, I know this is a tough topic that we're talking about, but I wanted to at least make a comment in regards to some of your testimony regarding, you know, DC and budget office and Kentucky and Texas. First of all, this is Georgia, and this is Georgia citizens. Georgia leads, it has led, and it will continue to lead on this issue. One, I don't know if anything's going to get solved in Washington, D.C., okay?
We've had that conversation, you're right. Yeah.
Second of all, other states, you know, again, Georgia leads, it does its own thing, and the states are different, have different laws set up. But I want to at least, I want to end on this comment, because you brought something up, and I think it's worth noting. You know, these people are, you say, sophisticated buyers, okay? I'm not sure how sophisticated they can be when they cannot see all of the contracts. And in regards to the state of Georgia, we are going to get sophisticated, because we are going to look at this. We're writing upwards of $4 billion for Medicaid, and even more when it comes to the state health benefit plan and the other plans that we fund through taxpayer dollars. And so, quite frankly, That's something we're going to look at. We will be a sophisticated buyer, and we'll be able to make a decision on. I appreciate your testimony. Thank you.
And I think, we've talked about that. Yeah, I think obviously to the extent the state health benefit plan is an ERISA plan, if you will. It's actually an ERISA exempt plan, but same concept applies. It's not regulated. But you are the regulators. You are the designers. You're the owners as the legislature. You can do whatever you want with that plan. Experiment away, and
Thank you.
I hope you can rein in
Thank you.
costs.
I appreciate your testimony.
Thank you, sir, for letting me.
We do agree some transparency and a role we can play will help. Thank you. Karen Woody, and then Shelley Williams after that. We're going to try to keep these last ones. If you can approach 2 to 3 minutes at the most, that would be appreciated.
I am Kevin Woody, and I'd like to thank the committee chair for allowing me to speak today, Representative Cooper, Representative Knight. I want to talk to you just briefly about our plight. I'm an independent pharmacist in rural North Georgia. In our town, there's one doctor, there's our pharmacy. We provide so much health care and everything above for these patients. Matter of fact, during this meeting, I got a text from a hospice patient who passed. His daughter texted me, and she just passed. I'll be doing his funeral in a couple of days. But we provide care for these patients. They have our phone number. They call in the middle of the night when they need us. And without us, what would these patients do? I'd like to start real quickly with the question of audits. We recently went through an audit, and they are time-consuming, they're expensive. But I want you to understand that when we get a notice of an audit, it tells us that in compliance with the fraud, waste, and abuse part of our contract, they are coming to audit us to make sure I'm not preventing fraud. The last audit that we went through, one of the major focuses was a prescription called Vyvanse. If you have a child with ADD, you know exactly the cost of Vyvanse. We're talking $450 a month. The purpose of this audit, like I said, 30% of those prescriptions that were pulled were for Vyvanse. Vyvanse has always been dispensed in a capsule form. The company makes a chewable tablet, but it's hardly ever dispensed. Most people don't even know it's made. The PBM, when they audited us, kept looking to see if the doctor had written capsule or tablet on that prescription. If they did not, they looked to see if we called to verify, and if we did not, guess who paid that $450? That money went back to the PBM. Now, this was under the guise of fraud, waste, and abuse. Our prescription audit was for 123 prescriptions. You say, pharmacist, that's not many prescriptions. Well, you need to understand how this works. I get a notice of books of 100, as was mentioned earlier. I had to pull 99 books of 100 prescriptions. I had to go through each of those to make sure those prescriptions were there. I wasn't told what prescriptions were going to be there. If a prescription had 5 refills, I had to make sure I had signatures for all 5 refills. The last audit took me 4 weeks. I would work my drugstore during the working hours. I would go home. I would get a sandwich. I'd come back and work till 3 in the morning until my computer cut off to run reports. I'd get up, come in the next morning. I did this for 4 weeks straight. That's dangerous. And it's time-consuming, and it costs me money and time for them to come and find nothing for recoupment. Next, I'd like to talk about managed Medicaid. Every day, we are reimbursed less than we purchase drugs by managed Medicaid. You heard of the examples of the pharmacies that did 650 prescriptions, and yet they paid almost $40,000 out of their pocket. I want to remind you, this is not profit. This is being reimbursed less than the cost of the drug. I want to share with you a story real quickly about a young lady named Courtney who grew up in our community. I watched her from a baby come along. She's a patient at my drugstore. She got a prescription for Adderall. At that time, the prescription, she would pay a $30 copay at my drugstore. She went to a chain drugstore. She paid a $30 copay. I was losing $30 on that prescription. I was reimbursed $50 from the PBM. The patient paid $30. That's $80. I was being reimbursed $30 less than I purchased the drug. She had a little handy app on her phone and said, well, look at this. This is where I get my prescriptions. It tells everything about it. When I went to brand X chain, I paid a $30 copay. The chain was paid $89, and obviously that was more than I purchased the drug for. You were told this evening that PBMs want to lower the cost of drugs. They own chain pharmacies who purchase a whole lot cheaper than I do, and they paid themselves a whole lot, $39 more for that prescription. You say, well, why would they do that? Anybody ever seen a bill from a hospital? You ever noticed how you get a bill and 2 Tylenol costs $13? Well, that's because there's cost in nursing care and everything else. But when I'm gone and I cannot provide for these patients, there's nobody here to tell you that, Mr. Chairman, that Advil didn't cost $300. Had a lady come into my drugstore the other day, and she said, I need to cost on Omnicef, a generic prescription drug, antibiotic. I told her $48. She said, she looked at me like she was just so angry. I thought, what have I done? I cut this for her. She went to one chain, it was $148. I could remember because it was $100 more. She went to another chain that was owned by a PBM, it was $168. My cash price was so much cheaper. And then we mentioned just a moment ago about the dispensing fees. Well, pharmacies are paid a fair dispensing fee. Well, what wasn't mentioned is when a drug is assigned a maximum allowable cost, there's no dispensing fee in that. There's this much that we're going to give you. Last night before I went home, I had one last prescription. Lady come in, child was on Medicaid, Amerigroup as a matter of fact, and I don't know if I can tell that, but the child needed a prescription for Prozac. It was a teenager, they'd been in treatment, came home, needed something right then. I run the prescription through, cost me almost $5. I was reimbursed 66 cents. Now you can do the math, $5.66. Now, I have a bottle to buy at $1. I have a label at 15 cents. I have a tech I'm paying. I have power. Now, the PBM's not paying these for these bottles of inventory. They're not paying techs. They're just skimming money off of this. They're reimbursing us less, paying themselves more. I encourage you to please support these bills and support independent pharmacies who, like in our town, are the only source of care for these patients. Thank you.
Thank you for your testimony. Bethany Shera. Thank you for being brief or concise.
Yes, sir. In the interest of time, I will keep this very brief. My name is Bethany Scherer. I'm here on behalf of the Medical Association of Georgia, on behalf of our 8,400 or more than 8,400 physician members in all specialties and all practice settings. We proudly support this bill on behalf of these physicians' patients, and we just want to see these reforms go in to make sure that there's better care of patients. And I think that the patients that have been here today can say this much better than I can about why this is so important, but this truly is one of the most important things that we can do to improve access to quality care for patients.
Thank you.
Thank you.
Is it Shelley Williams? Appreciate you saying that, Bethany, about the physicians and the prescriptions and having a pharmacist available to prescribe them, to explain them, to make sure the patients are taking them correctly is a key part of the care path. Ms. Williams, thank you for being here. We are on a tight time schedule. Thank you for your consideration.
I'll make this quick.
Thank you.
Try to. Thank you for having me. My name is Shelley Williams, and I am a Georgia pharmacist. I'm here today just to thank y'all for the work that you're doing and ask for your support on these bills. I would also like to share a bit of my story as quick as I can and experience as a former independent owner. I'm a second-generation pharmacist. My father owned a pharmacy for about 25 years, so I grew up around pharmacy, and I'm proud to say caring for patients is just in my blood. My father sold his pharmacy when I was younger, and it had been my dream to someday open up a pharmacy of my own. In 2015, I took the plunge and opened a pharmacy in Douglas County, which is also where I grew up. Because of strong community ties, I'm proud to say that my pharmacy, from a volume perspective, thrived with a number of community members trusting me with their care. Despite realizing my dream, in many ways it became a nightmare while my business grew with more and more patients walking in the door thanks to referrals and a reputation for patient-centric personalized care. The pharmacy struggled on the business side, and around 2017, things began to feel dire. How can you have growth in patients and growth in revenue, but still struggle, you may ask? Business practices by PBMs and Medicaid managed care companies is the answer to this. These practices include steering of my sickest patients to pharmacies owned by PBMs. PBMs also became more and more aggressive in charging retroactive fees and audit practices, which resulted in losses of thousands and thousands of dollars to my pharmacy and overpayments by patients themselves. Finally, a large percentage of my patients received benefits through Medicaid managed care, and the reimbursements got so bad that I began finding myself losing money on a huge portion of the Medicaid managed care prescriptions I filled as well. Business conditions became so bad that I was no longer able to afford the help of another full-time pharmacist, which made it difficult for me as I'm also battling breast cancer at this time. Losing money, having to take out loans just to stay afloat, what looks like a thriving business, and my being able to afford necessary staff support, I should have closed earlier, but I refused to do so because as important as fighting for my business was, I felt an obligation to be there for my patients. The negative impact of PBM and Medicaid managed care is hard to understate. They consistently delayed and fragmented care as a result of steering and by allowing their profits to drive patient care as opposed to sound clinical decisions. In conclusion, I'm sad to report to you that despite my efforts, in late 2019, I was forced to close my doors. Due to the practices of PBMs and Medicaid managed care, it became impossible to stay afloat. Ironically, although my business is closed, there is still PBMs still recouping money from me retroactively. It is insane. While it is too late for me, it is not too late for my patients, and that is why I'm here today. The transparency and patient protections in this legislation is great for Georgia patients and good for the state, and carving out prescription benefits from Medicaid managed care will help pharmacies stay open in areas where patients need care the most, save the state money, while at the same time cutting out the corporate profiteering in Georgia's prescription drug market. Please vote in favor of these bills and put the patients and providers first. Thank you.
Thank you for your testimony. At this point, Dorothy Glasser. Thank you for your participation. Appreciate you.
I will make this brief because some of my colleagues have already spoken, and I doubt I could improve much on what they've already said. I am the leader of the RX and Reach Georgia Coalition. We are a 39-member health-centered physicians and nurses organization. We advocate for legislation that ends the financial and discriminatory barriers to securing vital treatments and prescription drugs for patients. We've worked hard under this dome for the biosimilar bill, for the step therapy bill, and we're here today to lend our support to these three bills. They will provide greater transparency, financial relief, and oversight of practices that block the care to patients. There are too many non-physicians playing outsized roles in our healthcare system, making medical decisions, including which prescription drugs patients may take, and also how much they will pay for them. RX and Reach is alarmed as we hear stories every day about too many Georgians struggling to access and afford their medications. Patient assistance programs, rebates, and discounts are vital to our in most need patients battling serious chronic illness. Patients should not have to battle their illness and fight every day for affordable access to their drugs that will keep them alive and improve the quality of life. Our healthcare delivery system asks too much of patients and gives back too little. We support this legislation, and we want patients to be able to access their medications and have the opportunity to have better health outcomes and put the practice of medicine back in the doctor's hands where it should be. We believe Georgia can have a better, more equitable, and affordable access to a prescription market when we choose patients' health over profit. We applaud our bill sponsors, Representative Knight, Chairman Cooper, for their efforts to put patients first in Georgia. Thank you.
Thank you very much for your testimony. Is Bob Schmidt here? All right. If what you've wanted to say has already been said, feel free to. Now, were you in support or? Thank you. Okay, thank you. Thank you for that. Thomas Yusu, thank you for being here with us. And then one more after that, and so thank you all for your participation and patience on this important issue. Committee members, thank you for being here.
Thank you for the opportunity, ladies and gentlemen. My name is Thomas Yusu. I'm a pharmacist and also the owner of Ben Hill Pharmacy on Campbellton Road, not far from the Georgia Capitol. Until a few short months ago, I was also the owner of Eastlake Pharmacy on Glenwood Avenue, which is about 10 minutes from this area. I had started Eastlake Pharmacy in 2012 and specialized in serving Atlanta's medically underserved population, and many of those were Medicaid managed care patients. I know there has been a lot of talk by the PBMs about how well independent pharmacy is doing and prospering. I'm here to tell you that because of underwater Medicare managed care reimbursements, steering a large portion of my patients to PBM-owned mail order and specialty pharmacies, retroactive fees, and abusive audits, I was forced to close my doors at Eastlake Pharmacy. My second pharmacy is hanging by a thread. And to tell you the truth, when I closed my pharmacy, I did not gain a penny. I did not sell it. I just closed my doors. I did not sell my assets. I took a complete loss. Now, the reimbursements are very, very poor. Like yesterday, the gentleman addressed this earlier. I got paid 61 cents for spending $2.38. As hard as it is for me personally, my heart truly breaks for my patients who relied upon me every day in the area where, despite being in an urban environment, in many ways is a desert in terms of access to care. Often I was the only provider my patients saw on a regular basis. My employees, I had to wait many times for them to cash their checks before I could cash mine. Several paychecks I could not cash. I can't tell you how much it means for these pharmacists to see the work you're doing on behalf of my patients to help address what I believe is a crisis to care and an existential threat to not only the health of Georgians, but also the existence of pharmacies like mine. I will ask for your favorable consideration of all three of these House bills, HB 918, HB 946, and HB 947. Tackling, steering abusive audit practices and the lack of transparency are critical. And as to HB 947, I know changing the system is hard, but I believe carving prescription drug benefits from the Medicaid managed care companies and putting them back in fee-for-service will not only improve patient care and save the state millions of dollars, but it will give pharmacies like mine, providing care to Georgia's most vulnerable populations, a fighting chance to stay open and providing care in rural metropolitan areas where patients need it the most. Caring for Georgia's Medicaid managed care patients was what I took the most pride and joy in, and was also the primary reason I was forced to shut my doors. Please, please, ladies and gentlemen, please vote in favor of carving prescription drug benefits from Medicaid managed care. Thank you very much.
Mr. Juicy, thank you for your Thank you for your testimony, and thank you for your commitment to patience. Chairman Knight.
Thank you, Mr. Chairman. I just want to make a comment, and Thomas it came the other day, and he's taken off, even in the situation he's in, having to get somebody to come in and fill in at his expense. And I want to say, when I met him the other day and heard his story, it was one of the most compelling stories of how a person such as himself and many others are out there truly taking money out of their pocket to help care for the people in their community. And oftentimes we're talking about rural Georgia and the desert, the healthcare deserts in rural Georgia. But I want to make note to this committee and for all those listening, it's just not in rural Georgia. Thomas, you said your pharmacies were no more than, what, 10 minutes from the Capitol?
Yes.
And so I want to make sure this committee knows, and all those who are listening, that Thomas is an example of the healthcare desert that exists here in Metro Atlanta. And I want to say thank you for what you've done and for you taking time again and again to come here and give your testimony. And I appreciate you, and I appreciate the sacrifice that you make and all the other pharmacists make to take care of people first and put them first in front of profit. Thank you.
Very much. Thank you.
Thank you for being here. Your passion and compassion come through very clearly, sir. Greg Rybold.
Thank you, Mr. Chairman. I appreciate the opportunity. I'd like to use the next hour. No. Okay.
Turn the lights off.
I'll be brief. I represent the Georgia Pharmacy Association. It's my honor and privilege to do so, and here to strongly support all three of these bills and commend Representative Knight and Representative Cooper in this committee and this body for being willing to tackle these issues. Again, I think I'd like to make one very brief point with regard to the Medicaid managed care and probably concede a point because Jesse Wethington, I don't know if he's still here, if we've lost him, but he made the point that pharmacy costs have the potential to increase somewhere in the vicinity of $90 million or so. And I would note that what's really important is this bill contemplates an actuarial study to be done by the state of Georgia, state's Medicaid actuary, who are looking after Georgia's best interest to assess these things. And the fascinating thing is, when there have been actuarial studies done, pharmacy costs increase because you go from paying essentially a $1 dispensing fee to a fair $10.63 dispensing fee. Pharmacy costs go up. But here's the thing that the studies show. It saves the state money while it pays providers more. Not just independent pharmacy, all pharmacies, all retail pharmacies. And how can that be? How can you increase $90 million in dispensing fees? $90 million, but yet it still saved the state money. And if you read the bill, you start to get a hint because you see $100 million dividends going up to parent companies. You see $100 million going for admin fees out of the gate. We know in the last 2 years that there's over $90 million in spread pricing, $90 million. And CMS basically mandates and dictates that spread pricing is, in fact, administrative cost. So that's how. And the Medicaid actuaries can get at that, and they can study on it, and then we can act on it. But that's all that we're asking for here. And I would also note that there was some reference made to an agreement between the association or an accord and the Medicaid managed care companies where they voluntarily agreed to move away from spread. I would note I was shocked, frankly, to see that there is still a spread of, I think, upwards of $40 million for 2019. And I would also note that they agreed to move away from the spread because they were afraid we were going to seek a carve-out in the 2019 year. And so with that, I'm happy to answer any questions, but we throw our full support behind this legislation. This is good for patients. This is good for the state. And we look forward to working with this body and this committee. Thank you.
Thank you. Thank you. And thank you for the pharmacists that are like Thomas Jusu, who are out there every day with those patients who need it desperately. We will conclude the meeting in just a moment. We will be reassembling our team in the morning. The committee will meet again at 8 a.m. in room 506 in CLOB. We will look forward at that time to voting on the measures we heard on today, including House Bill 888, House Bill 918, House Bill 946, and 947. I appreciate your attention to this. For those that have traveled a long way to participate and bring us knowledge from all over Georgia, we appreciate it, and the meeting's adjourned.